webinar. Today's topic on the webinar is going to be indirect costs. This is our third module in the BEAM webinar series. So we're going to be going into depth around indirect costs. So I think a couple housekeeping things before we get started. One of the things we just want to continue to emphasize is the importance of having not only your clinical folks, your clinical program folks on the line today, but also to make sure that your finance folks are participating as well. One of the things that we've learned from our BEAT project is how important it is and how much better agencies are doing when the finance folks and the clinical folks are working together. So thank you so much. And then in addition to that, just a reminder that all of our registration, our notes, our videos will all be available on our website after the completion of the webinar. It'll probably take a day or so to get up there, but it will be up and available on our website. And just also one thing that had come in to just check your spam email, because sometimes some folks have their spam, our email goes into their spam, so just to be mindful of that as well. So today we are going to talk about, we're going to recap a little bit from last week. And then Dewey's going to go into a lot of detail about indirect costs, what they are, some conversation about workflow for administrative personnel, non-controllable indirect costs, some of the controllable indirect costs, how to set productivity expectations, some future considerations, and benchmarking and those kinds of things. I'm going to come back on and talk a little bit about action steps going forward, and then we'll wrap some things up at the end and then wrap up the webinar by 1 o'clock today. So last week we went through the quick analysis tool. From the benchmarking tool, and I thought Chris did a nice job of walking everybody through the quick analysis tool 2 weeks ago. And then last week we had a bunch of folks on the call for our office hours, and we're hopefully able to answer questions. And just a reminder, we'll remind you at the end, please submit any questions for the office hours either at the end of this webinar or in our separate email that goes out next week. Prior to the next webinar, because it really allows us to prepare to be able to answer as many of those questions as possible. So what we asked you to do as your kind of action steps after the last webinar was to go through the benchmarking tool with your core team to really start to review the indirect cost section of the benchmarking tool in preparation for today's webinar, and then to meet with your team to discuss what costs account for your agency's indirect costs. So before we jump into the big content, we're going to have a couple polling questions. So first, did you log in alone today, or you logged in as part of your core team? So if one is logged in by yourself, logged in with up to 4 people, or logged in with more than 5 people. It looks like we skipped ahead to the second polling. Okay, so it looks like we've put up the polling question for the end of the webinar. So, Ev, if you could close that out and put up the first polling question, which is entitled Polling Question 1. There we go. All right, so if you folks could just answer that, did you log in alone or as part of your core team? Just real quickly, logged in by yourself, logged in with up to 4 people, or logged in with more than 5 people. We'll leave a couple seconds for folks to answer, and then we'll wrap up that poll. Sorry for the quick hiccup there. Evelyn, when it hits 25 seconds, why don't we just lock it down and we'll report the answers. Okay, so it looks like about 48% of folks are logged in by themselves. We have a bunch of folks who are logged in with other people, and then some other people who are logged in with a large group. So that's great to hear. We really think, obviously we've got all of ourselves logging in from different places, but it's also good and great to hear that we've got a couple people, a good chunk of folks who are logging in with their group. The next webinar is just the next polling question. Is around what is your role in your agency. So just A for finance or leadership, B for clinic leadership, executive leadership, clinician, or professional staff. And Justine, I give about 20 seconds or so, and then we'll close this one out. Okay. So we're still scoring. All right, we should see the scoring in just 1 second here. Okay, so it looks like we've got about 15% of folks are from finance leadership, and we got about 30% of folks are from agency, from the clinic leadership, and then a good chunk from executive leadership, and then some other folks as well. So that's great to see. And then our final webinar, our final polling question before we jump into the big content is: do you feel like you understand how indirect costs impact your clinic finances? So if you could just answer yes, no, or unsure, and then we'll go from there, and then Dewey's going to explain to us exactly how indirect costs do affect our clinic finances. So Justine, when we hit 25, why don't we shut it down? Okay, the results should be up in just a second. So the one thing that we're going to try to figure out, I guess there's no way, it's just a limit of the technology, is exactly how to speed up the scoring of the system. We're pretty pleased with our webinar system, but the scoring of the polling question seems to take a little longer than it should. But hopefully it will be up in just a moment. We may also have to get a soundtrack of some Jeopardy music in order to play the Jeopardy music while the polling question gets scored. I think that might increase the suspense building. So hopefully it's coming up in just one moment. Okay, so about 14% of folks, 49% of folks do understand how it impacts their finances. Smaller chunk said no, and then a pretty medium-sized chunk said that they're not sure. So with that, I am going to pass this back to Dewey, who is going to walk us through the more details around the financial situation with indirect costs. So Dewey, I give it back to you.
Well, thank you, Andy, and good afternoon, everyone. It's a pleasure to be here with you today, and it's a pleasure to be able to present indirect costs. By now, I'm sure everyone has looked at our benchmarking tool that we've handed out, and it's now in your possession, so it's your benchmarking tool as well. And when you look at that, you see several tabs and you see several words in there, and it's good to see that most folks have identified what indirect costs are and what direct costs are. And so when you go through this today, and when we go through this today, my hope is that at the end of this conversation, that everyone will have a clearer understanding of what indirect costs are and what we can do about indirect costs, and what we need to do about other types of costs that go into the benchmarking tool. So I guess when we start the discussion about indirect cost, we should make it really clear that we've broken this out between direct cost and indirect cost as the cost base for the financial planning tool. In the direct cost model, there are some indirect costs that will come over to the indirect cost tab. For example, if you have a clinician that operates sometimes as the director of the clinic and sometimes seeing clients, that percentage would be indicated on the direct care cost tab, and it would come over. So I'm going to leave that because at the next seminar, next webinar, that's going to be discussed in detail. But just be aware that there are some indirect costs that are directly assignable from the direct care cost category. So we'll leave that where it is. Indirect costs, however, are something that have no direct relationship with the actual provision of the service. So the indirect cost, as we look at indirect costs, are things like the rent, there are things like the electric cost, there are things like insurance, and there are things like fringe benefits. Those are some examples of indirect costs. There are also examples of non-controllable indirect costs. Once a lease is signed, the clinic has no control over what the rent is. The electric cost are the electric costs, and insurance is the same as rent. Once you sign up for your insurance policy, there you are. And fringe benefits, quite honestly, are an allocation that are usually derived in the finance department and assigned to each program. They're based on what the fringe benefits are for either a union or a non-union shop and those types of things. So there are certain components of indirect costs that a clinic can't control directly. Also, you can see these costs. One of the things that's really important and one of the things that have been stressed over and over again is the need to get a monthly financial statement for the clinic. A monthly financial statement for the clinic details the revenue that's received or the revenue that's accounted for, and all of the costs, personnel costs and total what we call OTPS, or other than personal service costs, and you can see how the clinic is doing. Revenue minus expenses is where you stand in a surplus or a deficit position, and it's the way us finance folks look at programs to see A, if there is a surplus or a deficit, and B, if it's on budget, and to see if there needs to be some type of detailed variance analysis. So all clinic programmatics, all programs actually, should be getting at least a monthly statement of revenues and expenses, and that, when you start using your tool, you should make sure that it ties back to your monthly expense and revenue statement. So when you look at that and you see what's specific to your clinic, you'll see certain listings of cost. And like I said, there's going to be indirect cost and there's going to be direct cost. And in the indirect cost category, you need to identify what's controllable and non-controllable. When I say non-controllable, I don't mean that you have no control over it. I mean that it's assigned to the clinic, and the clinic takes that each month and each year as part of their cost structure. It doesn't mean there shouldn't be a discussion with the finance folks and an understanding of how those costs get there. Now there's controllable indirect costs, and you can see from the slide that the controllable indirect costs that we're talking about are staffing and other costs that you can control. A clinic can control the staffing, how many front desk people we have, how many clinic directors we have if they're not seeing caseloads, how many other types of administrative people are needed to deal with the operations of the clinic. That's the staffing. The other types of costs that can be controlled, other than personal service or OTPS, are things like supplies, are things like computers. Do you need a new computer or not? Are things like, our internet's too slow, should we increase the bandwidth of our computers so that we can do things a little faster? So there are things that are controllable by the clinic director, and there are things that are non-controllable by the clinic director. As we move to the next slide, I just want to go over one more time, if I could, the concept that clinic management should receive an internal monthly clinic expense report. You should be reviewing your clinic expense report, and you should be open up a dialogue with the finance department if there's any questionable cost on there. Very often there'll be costs that need to be detailed, but you need to take a look at that, because at the end of the day, that's how the success and that's how the surplus and deficit of the clinic is being judged, based upon the costs that are getting allocated to the clinic. So we'll move now to controllable direct costs, indirect costs I should say, controllable indirect costs. So when we talk about staffing, and everyone will take a look at their clinic and they'll say, you know, the staffing we have, other than the clinical staffing, the staffing we have is absolutely, positively essential for clinic operations. However, if you sat down in the clinic and you started thinking about how does the workflow go, and I'll get into that on the next slide, but if you start thinking about how the workflow goes and you start asking people what do they actually do, or you start observing what people actually do, there may be a different answer to that question on that. So you always want to start with your staffing. You always want to understand what each job is in your clinic. You want to understand what the job function is, and you want to make sure that that job function is essential to the operations of the clinic. And as we go through our discussion today, I'll be talking a little bit more about that and how we parse out different job duties and some of the thoughts. I'll be leaving you folks with some thoughts on how you may want to take a look at your clinic in the future. So we want to make sure that any allocations into our clinic, it's one thing to know that Sally Joe works in the clinic and we see her every day from 9 to 5, Monday to Wednesday, or Monday to Friday, and we see her there and we know she's there. But all of a sudden, there could be an allocation of somebody else who may or may not work directly in the clinic, may or may not have things to do with the clinic, but may appear on the cost report for the clinic. So it's really important to, A, understand what the allocation is. And again, in this day and age, when somebody's allocated to a specific program within an agency, it's really important that that allocation is correct, number one. Number two, it's supported by time studies. As you report clinics in the state of New York and you're reporting on the CFR, there's a whole detailed explanation of how you deal with allocated employees in the CFR manual. So it's really important that if you see an allocated person, there's a clear understanding of that time that the person works in the clinic, and there's a clear set of time studies that have been done to support the fact that that person actually works in the clinic. So when we take a look at that, we would, yes?
Julie, I just wanted to jump in and just add one thing on that. Is that one of the questions that came up when we were working on with the BEEP clinics, was especially for programs that are like embedded in hospitals or other systems, is that they had staff who were in the clinic on the cost sheet full time, but they often got pulled out of the clinic to do other things in other parts of the agencies. And so one of the things that they were figuring out how to do was to make sure that they only had those clinicians allocated to the clinic for the amount of time that they were actually spending in the clinic performing clinic services. And I just wanted to highlight that because I'm sure there's other folks who experience similar things.
Yeah, that's a very good point, Andy, and it's really, really important in this day and age that we understand what the gold standard of allocations are. That when somebody's allocated, when somebody's allocated into the clinic or allocated into any program, that there are time studies that back up that allocation, and there is an understanding within the organization of why that person is being allocated. So it's really, I think it's really, really important to do that. And then once we understand what our permanent staffing is, our regular 40-hour work week people or our 35-hour work week people, depending what it is, and then we understand who's being allocated to the clinic for the hours that they're being allocated, I think it's important to do a workflow analysis of your staffing pattern. And so you really want to understand what is the workload of the administrative people, so to speak, in the clinic. And so we've developed, and there's a slide that you see now, we've developed a sample. This is really nothing more than a sample of what could possibly happen in the clinic. And so when you see this workflow analysis that we've put up here, and you take a look at these 5 boxes, you'll see that we put certain tasks within the boxes. The next step would be to understand if this is actually a workflow analysis for the administrative personnel in a clinic that makes sense. If that's true, if these tasks that we put in here were absolutely the only tasks that people do, the next thing to do would be to assign people to the task. Who does the intake of the data entry? Who does the schedule for the appointment? I'm reading now from the top box on a new client admission. Those types of things. How many admissions do you have, for example? how long does it take to do this data, and what makes up the rest of the person's workday. And so what you do is you take the workflow first at a very high level without getting into details. You'd put that in a workflow analysis. You then assign the people to the different tasks once you've identified all the tasks, and then you assign time to the people of what they need to do this workflow. And once you're able to do that, you could then see if there is excess time, for example, of people within the administrative personnel of a clinic, or you could see if there's duplication of data entry, for example. Sometimes duplication of data entry happens in the same system. Somebody could be entering data for admission. At the same time, whenever there's a visit, the same type of data could be entered within the system. So you have to be aware that there could be duplicate data entry, which is never a good situation. It's always important to strive, again, the gold standard is if you need a piece of data, make sure it's entered once and make sure it's verified. So you don't want to be entering the same data in two separate places in the system. That doesn't mean that certain clinics won't have two systems running at once. It's very possible to have two different types of systems where you need to enter the data twice, once into one system and once into another system, or once into one system, once into another system, and then on paper. So you should be looking at these tasks that flow from your administrative personnel workflow and look at the tasks and see if there's any, A, duplicated tasks, B, if there's any tasks that are being done twice, and C, who exactly are doing these tasks. And once you get that lined up, and once you take an analysis of this, you may see that there's certain duplications, you may see that there could be certain savings, and you may see that your scheduling is much too broad for the tasks that are at hand. And so that's the purpose of having an administrative workflow, is to understand exactly how the work flows, exactly what documents are needed, exactly who does what, and how long it takes them to do that. So that's why we've shown the administrative workflow analysis. You can do it any way that makes sense for your clinic. Again, this is simply an illustrative model showing you how easy it is to do it at the 10,000-foot level, and telling you that it's really important to put people with the task. So once you have the task, again, once you have the task accumulated, it's really important to put the people to the task and then put the amount of time the people spend doing the task. When you take a look at this as well, it should all roll forward from your policies and procedures. You should have policies and procedures, administrative policies and procedures within the clinic of who does what and how they do it. And if you do have policies and procedures, you can then have individual work tasks that each employee knows on a daily basis, on a weekly basis, and on a monthly basis. And some people would call that a script, and some people actually are able to put that right at the employee's workstation so the employee knows what their requirements are each day, each week, and each month. So that's the discussion of the administrative workflow. From the workflow, from the understanding of all the tasks at hand, comes the ability to set productivity expectations. And you know, it seems kind of strange to be talking about indirect costs, to be talking about administrative personnel, and to be talking about productivity expectations. But that's the way you run an efficient organization, is by understanding what people are expected to do. Now, I've spent a little bit of time going back and describing how you would go about doing that. However, what we found is productivity expectations, of course, vary from organization to organization. They can vary from union shops to non-union shops, but it's really important that people know what their productivity expectations are. So, for example, if you have a clerk whose job it is to input all the data for a new admission, how many of those can they do per hour? How many of those can they do per day? And exactly how many do they do? So not only, you know, here's your expectation, but who's monitoring the expectations and when you do that. And so we've been talking about, or I've been talking about, in, you know, the staffing, I've been talking about productivity, I've been talking about how you measure that. again, when you look at this, when you look at people in the administrative function, given that it's the 21st century, given the technology we have today, is there a way that the functions that people are doing out in the clinic, are they being duplicated someplace else within the agency or within the organization? Is there a way, perhaps, that if you can't get economies, if you can't get productivity expectations, is there a way that you could centralize some functions? And if you centralize functions, would that drive down your indirect cost? So if you need 3 or 4 clerks to run a clinic, if you're able to centralize that someplace, if you have another clerk in another part of the organization that has the capability to do the functions that the clinic is doing, would you be able to reduce the staffing and drive down your indirect cost? I think everyone on the phone would agree that indirect costs are something that we should drive down as low as possible to protect ourselves on several fronts. The lower the indirect costs are per visit, and I'll talk a little bit about how we measure that, the lower the indirect costs are per visit or in the clinic, the greater our ability is to show a surplus of revenues over expenses. And that's what we're trying to do, either break even or show a surplus. So if we're able to drive the indirect costs down, and some clinics apparently have done a very good job of it, it gives us the ability to show a surplus of revenues over expenses. And needless to say, if you read today's headlines, the headlines of today, not necessarily today, but this week, you'll see that a lot of the Medicaid revenue in the state of New York is at risk. It's really important to be able to set ourselves up to understand, the revenue that we have today may not be the revenue that we get tomorrow, and how do we move that? So flexibility, believe it or not, is also important in indirect costs. So if we understand where our costs come from, we understand how we can control those indirect costs, and we understand that we have an ability to perhaps move some of those costs or drive those costs down, it puts our clinic in a much better position than the clinic up the street, for example. And so it's really important to understand in the administrative context that there is an ability to do centralized intake, there is an ability to do centralized data entry and things like that, and you need to take a look at that. You also need to take a look at some of the administrative tasks to see if they're being done by administrative people or if they can be done as part of the visit. A whole different discussion, and when we start talking about in Module 5, when we start talking about CPT weights, and you start talking about utilization in Module 6, and we start talking about Model 7, where we're starting to analyze everything that's come together for effective decision making, you may want to see that some of the functions can be carried on by somebody who's closer to the function than the administrative personnel, again, giving the clinic the ability to drive those costs down. And that's what this is all about. That's what indirect costs are all about, is understanding how to do it with the proper amount of cost and understanding what the variability is of those costs and understanding how somebody can change those costs or how a clinic can change those costs. So I think that's really an important consideration, not just accepting what's there, but trying to figure out how to do it better and how to drive it down. And I think that's one of the great things about this collaborative, is there's a lot of techniques that can be shared, there's a lot of numbers that can be shared without obviously identifying any one clinic, but there's a lot of things that can be shared and how to drive these costs down, because costs are something we want to drive down, revenue is something we want to drive up. So that's where we're coming from on the indirect costs. Again, when we start thinking about where we are in technology and we start thinking about how we're operating our clinics, we can't have that discussion unless we understand what can be automated. What tasks are being done now? What are being done manually? Are we completely on our medical record, on our EHR? Is our EHR completely implemented? Do we have the ability to scan things behind the EHR so we're not keeping a paper record? Because once you get to the point of keeping paper, it's always more expensive than not keeping paper. Once you set up a separate system that you do something in your automated system and now you have to do something in paper, it takes more people to do that. So when you look at the task, when you go back to your workflow and you look at the task, understand what can be automated and what can't be automated. I think that's really important to do. Okay. You know, the other part of the indirect costs that we're talking about, and like I was saying, is it's really important to understand that sooner or later, all healthcare organizations, all healthcare departments need to be paperless. Everything needs to be in the EHR, and it needs to be there for several reasons. But most of all, it needs to be there because the more you get into your electronic record, the less costly it should be at the end of the day. So you need to take a look and understand if there's a way to get your clinic to be paperless, which is a whole other process, but it's certainly something that could drive down your indirect cost very directly, and very importantly, once they're driven down, they could stay down there, and you don't have to pay for copying, and you don't have to pay for paper and things like that. The other thing that's really important to understand is the next bullet on the slide of future considerations. It's really great to get this monthly report. It's really great to understand every single line that's in this monthly report as they relate to expenses, whether they're indirect or direct expenses. It's really great to understand that, but what can happen if there's future costs? What type of future costs do we need to look at? And how do we take those into account as we move our clinic forward? If we're breaking a clinic even today, are we going to get hit with some large costs that we have to deal with? And you can see that we've listed a few of these considerations. RIOs, these are health information exchanges that run throughout New York State. RIOs are very expensive, and if you're going to use a RIO for your clinic information, and most people will be using a RIO, believe it or not, very shortly, you will see an increased cost. You'll see a cost allocated to the clinic, so that when you do have a health information exchange set up, you're going to have to pay the price for it. But again, will it drive down the cost, the actual cost of doing business within the clinic? Can there be an impact on the indirect cost? Even though we have an increased cost, we have to pay for the RIO, is there a way to look at the costs we now have and to drive those down? Or is there a way to use the information in the RIO? If we use alerts from the emergency room, if we use alerts from inpatient hospitalization, if we use other alerts or other pieces of information in the RIO, is there a way that we can use that to, number one, have a more effective treatment being done, and number two, drive down our administrative costs? Everyone knows that the ICD-10 codes are coming out. Have you taken that into consideration in your clinic? Have you done the training that needs to be done? Is that in your budget? And that, again, is an indirect cost. I mean, depending upon who does the coding in the ICD world or in your clinic world. And the DSM changes as well. Have you taken that into account? Are there going to be increases in your software costs? Are there going to be increases in your training? Are there going to be increases in costs due to the way that you do things within your clinic to take these changes into account? There's also other considerations for costs. Like I mentioned earlier, insurances and all those things, all those bells and whistles that go into the cost base of any clinic are going to do nothing but increase. So it's great to build a model that breaks even, but everyone should be aware that the costs are going to increase, and as the costs increase, what happens? Especially, you know, when we're looking at something that could be a perfect storm, where costs are increasing and our reimbursement is decreasing, how do we deal with that? We're going to give you the tools to be looking at where you are today. We hope you'll be able to use those tools, and we know you'll be able to use those tools to look at where you'll be in the future, and we know you'll be able to place certain what-if scenarios in the future as well. So when if the rates do decrease, you'll know what costs are easily identifiable, what costs you could drive down, or what costs you need to eliminate to be able to do that. That's the discussion of future considerations and what you need to take a look at as you move forward. We wanted to give you an idea of what the average benchmarks are for indirect costs, and so we've done a survey. We've gathered, like we said, we've gathered quite a bit of data, and we see a majority, probably the standard deviation is between 40 and 60% of your costs are indirect costs. So when you take a look at that, if you're below 40 or above 60, you may want to take a look at your costs to make sure that you're getting the proper accounting and to make sure that if it's not correct, it gets corrected. Or if you're above 60%, you might be considered an outlier when we look at the clinic data that we have. So if you're above 60% when we do the tool of indirect costs, you may want to question why. And again, we will have individual meetings, or we will have the ability for individual clinics to ask questions about their tool when we get there. So that's what we need to take a look at, and that's the good thing about this consortium is you're able to take a look at what everyone else is doing and see if in fact you're an outlier. When we take a look at the actual tool, the actual financial benchmarking tool, and I'm going to put my glasses on to take a look at it. Again, if we've taken a look at the actual tool itself, we know this is a tab within the tool. We know that it's completely interactive with the overall calculations, and we know that once you enter data here, it will interact with all the other pieces of data that have been entered. And it's a very, very straightforward approach on the indirect cost. So if you take a look at your people who work in the clinic director, the examples we have here, you know, are the typical ones: the clinic director, the billing staff, any training, a QA specialist, and we put in the FTEs. You can see that we've got salaries, we've got FTEs, and of course that comes into your total indirect cost. We then use, of course, a fringe benefit rate to calculate what the cost would be, and then you take a look at your other operating expenses, and then break out rent separately and any admin you have based upon usually the agency admin percentage that you can find on your CFR for an OMH program. So it's relatively simple to be able to build this up. It's relatively simple to do the data entry. Like I said, though, to get to this point, you want to make sure that you've got the appropriate people out, directly assigned into the clinic and directly allocated into the clinic, and that all allocations are correct. If you look at this, slide that we have up right now, you'll see that below the direct care side or the administrative side are the indirect is the indirect portion of the direct care staff. That's very hard to say, the indirect portion of the direct care staff. But as I mentioned earlier, you may have some direct care staff, people who are giving clinical services, and part of those people may become indirect care. And you could see that we've given you an example of that. And so it's important, again, to understand how those numbers are derived, and it's important to understand that those numbers should be correct, and it should be based on time studies again. So, for example, in the example you see in the direct care, and again, this will be going on in another module, but the example you see, for example, with the registered nurse, is part of that person has indirect care assigned to them. And the question is, how do we get that amount? And the answer is, we've done that with a time study.
So Dewey, if I can just jump in real quick. So like that nurse might be spending a quarter of their time doing utilization reviews or something like that, which wouldn't be direct care. Would that be a good example?
That's absolutely correct. Any function that nurse would be doing that's outside of client care or patient care would be indirect. And so you'd want to take a look at that because it's not producing revenue, and so you'd want to allocate that or assign that appropriately so it goes into your indirect costs, and that's why that person is there. Again, in our example, you'll see that we have a social worker who part of the social worker's time maybe, like you said, Andy, maybe you are, or maybe doing something, or maybe calling people, but doing non-billable services. And that's the way you gather up your direct care staff that do indirect type of services. Again, once you enter it in the tool, on this tab in the tool, it carries forward, and by the end of our modules, you will have a tool and you'll have an understanding of the tool on how best it's used and how we have enough variables in here so that eventually you'll see the really dynamic and direct way that you'll benefit from driving down indirect cost, if I could say it that way.
Joey, can I actually just jump in with one other thing, just another clarifying point. So for your non-clinical positions, like your billing staff, now that person might be full-time with the agency, but only half of their time is spent assigned to working on billing for this particular clinic, and so therefore only half of their time, half of their FTE would be listed in this clinic's benchmarking tool. And that'd be one of the things you'd also want to be looking in your financial sheet, your financial sheet you're getting every month from your finance department too, right?
That's correct, Andy, and that's a very good point. So if everyone takes a look at the slide we have up, you can see we have a half-time FTE, a half-time person as a billing staff. That doesn't mean the person only works 20 hours a week. It can mean that the person works 40 hours a week, 20 hours in this clinic, and 20 hours in another program. Again, that half-time, that 0.5 FTE, is supported with a time study. How much time do you work in this department versus how much time do you work in the other department? So it's really important to understand that, and it's really important to look at that. Again, when you do the indirect cost, and when you get to the direct cost portion of the clinic, it should tie out to the monthly financial statements that you receive from the finance department, or at least the finance department should be looking at this tool to make sure the numbers correspond to the numbers that are being reported monthly and being reported on the CFR. It's really important to go all the way to the end on this to make sure there's integrity of the calculations that are being done, so that if you do use a benchmarking tool and you do show a surplus of revenues over expenses, for example, that it's reflected in the financial statements. And that if you don't show a surplus of revenues over expenses and that your desire is to break even, you have every single component within this whole tool, not only in the indirect cost category, but also in the direct cost category and in the revenue category. You have all the tools you need to be able to drive the clinic towards a break even. And that's the important concept of this, is that once you've entered all the data in the tool, once you've verified the tool is what's going on in the agency's financial statements, you then can project whether you'll have a surplus or not, and you have control over every element that's within the tool. And that's the beauty of this tool. So I've done a presentation, I believe, on indirect costs. And I think that either I spoke too quickly or we've covered all the topics that we need to cover on indirect costs. And so I think I need to turn it over to you, Andy.
Fantastic. Dewey, thank you so much. Justine, if you can just pass me back to, I am now the presenter. So thank you, Dewey, so much for really clearly kind of walking us through exactly what indirect costs are and how they get allocated. And just, a couple points, I know that Dewey and I both mentioned this when we were talking, but this idea that, one, you really should, for the clinic folks on the phone, you really should be getting a monthly statement from your finance department, and two, to really be very mindful of what staff are are assigned and what percentage of their time is assigned to your clinic, your particular clinic's operations, and then also be doing time studies to make sure you kind of know what the amount of time people are spending on different things so you can allocate them correctly. So we have a polling question here that we'd like to launch. So if we can get that polling question launched, that would be great. So do you think your CIT, your core implementation team, has the information they need to complete the indirect cost section of the benchmarking tool? So just yes, no, or not sure. Give folks about 25 or 30 seconds to answer that, and then we'll see what people have to say. All right. Well, we'll get into our Jeopardy music, and then in a second we should have the scores on that. Okay. So it looks like about a third of folks said they did have the information they needed. About 10% of folks said they weren't sure yet. About 9% of folks said they didn't have that information. So one of the things that if you may need to work with your finance department to get some of that information. But also, as you have questions, I'll say this again in a couple minutes, but as you have questions, we obviously have our office hours next week, and so please feel free to send in your questions, and we can really work through those during the office hours next week as well. But it looks like about a third of folks have the information that they need. And then the last polling question is, do you think that you will immediately try to fill out the indirect cost section of your tool? So if you could just answer that real quick, that'd be great. And Evelyn, why don't we give people like 20 seconds or so and then cut it off? So if you're going to answer, folks, if you could just answer real quickly, I'm mindful of the time, and I don't want people to have enough time to answer, but not too much blank space. Okay, so it looks like about 20%, we have about half didn't answer. So it's about split pretty evenly among folks who are ready to immediately do it, folks who aren't ready to immediately do it, and then folks who aren't quite sure yet. So it looks like we're split pretty evenly there. And again, as folks have questions, please feel free to ask. So the action steps before the next webinar are pretty straightforward. So we'd really love for you guys to kind of review the indirect cost section of the benchmarking tool with your core team. Really see where, what information you're going to need to get if you haven't done that already. How to plug that information into the tool to start playing around with that and getting that plugged in. And then if you have any questions or things that come up you either don't understand, need additional information, or that we can kind of help answer for you, please send those in via the survey link below, and we also send that survey link out to folks. As we keep mentioning, it's important to have all the members of your team, really be part of these phone calls, so that we're all, I think, one of the important things is for some folks, and particularly for the finance folks, we know that some of this is stuff that they know, kind of wrote. But one of the things that we think is helpful is really, to get everybody speaking the same language is really important. And also to sign up for the discussion board, which we're going to be talking about later. As part of the discussion board, we're gonna do some more work on that in the next couple weeks. But we really are hoping that it can be a forum where people can talk to one another and ask each other questions that may be better suited for them and not us. So I just want to do a couple other housekeeping things before we wrap up for the day. Obviously, our training was today. Next week, same time, same place. Next week, we will be here between 12 and 1, and Dewey will be on the phone, and myself and Justine as well. And we'll be available to answer any questions, which you can submit via the link in the slides back here, and we'll also send out a separate email with that link for folks to submit their questions. We do take questions on the line that aren't submitted in advance, but it's always good to have as many questions as possible in advance, because it allows us to do any prep work that needs to be done in the background to answer those questions. And if we get the question on the line immediately, then we're not able to. One of the things that we're exploring as part of that process is asking the questions that have come in advance and then giving you all the opportunity to ask additional questions around those same topics. We're working on that, and that works much better. So that works much better. And then the next webinar on our next module will be on direct costs, and that'll be on the 15th of this month from 12 to 1. And then we'll have our office hours at the end of that webinar. And just another big push, on Monday we're having our next MTM series on collaborative documentation. Dr. Bill Schmelter will be presenting that. We had a really good response to the one on open access last week, and so we're hoping we have an equally good response to the one on Monday. We're really looking forward to that. And then on Thursday, March 14th, we'll have our final webinar series, a webinar with MTM on centralized scheduling. Just a reminder that we will be bringing MTM back over the summer when we're done with this particular item. So I think at this point I've got a couple questions that can be answered relatively quickly, and then if we have a moment, we may answer one or two others that have come in. So somebody asked, what are the RIOs that are referred to in the future consideration slide? RIOs are regional health information organizations, and they are being built up around the state to allow for the exchange of electronic information across medical records, particularly, so you'll be able to exchange information between your clinic and a hospital that would also be treating somebody, or a housing program, or those kinds of things. And so agencies around the state, particularly around the issues of health homes and those kinds of things, are starting to get hooked up with RIOs. And then, are you putting time spent in the supervision and clinical team as indirect? Yes. And so I think that's what Dewey is responding to around the issue of yeah, go ahead, Dewey.
Yeah, let's go back to that question. Could you read that question again?
Yeah, are you putting time spent in supervision and clinical team as indirect costs?
No. I think the answer on that is no. If you're dealing directly with the clinical aspects of the clinic, it should be a clinical time, because that'll be taken care of on the direct care side. If you're doing paperwork and things that are clearly administrative, then that should be there.
Okay. Now, what about what about the time, like for a supervisor who spends half their time doing supervision with staff? Would that be considered indirect, or would that be considered direct?
That would be considered indirect on the supervision with staff.
Okay. So the clinician's time in supervision is considered direct time. The clinical supervisor's time doing supervision with the staff will be considered indirect time.
Yes. Right.
Okay,
yes.
Great. And then we had two other questions, so since they're here, we might as well answer them. We got a couple minutes left. How does the indirect cost amounts compare to the overhead amounts on the 990?
Yeah, Andy, I think the best way to answer that is all agencies that have an Article 31 clinic do a CFR, Consolidated Fiscal Report. On the Consolidated Fiscal Report, OMH has a separate overhead rate. There's a calculation of a separate overhead rate. That's the rate that people should use to compare to their administrative costs. You can obviously build up the administrative cost piece by piece, or you could use that separate overhead rate that you find on the CFR. And just call your finance department and they'd be able to help you with that. The overhead rate that you look at on the 990 is usually a completely different calculation.
Okay, great. Thank you very much.
And
so that,
yeah.
Go ahead.
Oh, I was going to say that's where you should get it from the CFR. Okay.
Fabulous. All right, thank you very much. And then we had one follow-up question. We'll answer this real quick and then we'll wrap up. Somebody wrote in around the supervision time, but if it is time you can't bill for supervision time, how does the model account for it if it is listed as direct costs? So for the clinicians who are billing their supervision time as direct costs, how do you account for that, since they can't, bill for that time, obviously?
It would be part of your productivity, and I think that will be addressed when we start dealing with direct costs in the next module. And I think that's better answered with a lot of examples, and that'll be done in the next module.
So fantastic. So when we do our direct costs in 2 weeks, we'll address that in specifics with some examples that kind of lay it out for folks.
Great.
All right. Well, with that, I want to thank everybody for taking the time to join us today for our third module on our BEAM program. Please remember that when you get that email to send us any questions that you have for office hours, and we'll be glad to spend obviously a little more time during office hours going through those questions than we can wrapping up today. I want to thank Dewey for really walking us through this and explaining what all the numbers mean. For those of us who aren't finance people, it's really good to be able to have somebody to explain what all these things mean to us. I hope you found it helpful. I hope everybody has a wonderful weekend, and we will see many of you next week for office hours, and hopefully all of you back in 2 weeks to wrap up our, in 2 weeks to move on to our next module around direct costs. So thanks, everybody. I hope everybody has a wonderful weekend, and I look forward to speaking to everybody in a couple weeks. All right, take care.